So can everybody hear me? Can you just raise your hand if you can hear me, please? Thank you very much. Okay. Carol, Seema, you can hear me, right?
Yes, I can hear you.
Okay, thank you. So I want to just say good morning and welcome to all our live Global Breast Cancer Tumor Board, to all participants and viewers from around the world, and a special welcome to our colleagues from Dominican Republic who have joined us online today and will present a case at our next tumor board next month. A special thanks to the doctors who will present our cases this morning: Dr. Hugo Fuentes from Lima, Peru, Dr. Pedro Lica from Porto Alegre, Brazil, and Dr. Vanessa Daival from Salvador, Brazil. And a special welcome and thanks to our very prestigious panelists from MGH and around the United States. So thank you everybody for joining us this morning. And we'd like to start with the first case is from Dr. Hugo Fuentes from Inen in Peru. So Hugo, we're going to share the slides if you wait a minute, and we can have you, can you hear us? Turn on your microphone, and in a minute. Hugo, can you hear us?
Yes, hi,
okay,
good
could
morning
you start
everybody.
presenting your slides, please?
Okay.
There's Dr. Fuentes. And there we go. The first case, please, Hugo.
Okay, well, this is a case of a 22-year-old premenopausal woman that came to the institution with a palpable right breast mass. No comorbidities, family history of mother with gastric cancer. He came with a right breast lump, and in the physical exam, 9 centimeter breast mass in the right inner quadrant and a 2 centimeter mobile lymph nodes. In the CT scans reveals right mass 4.6 by 3.2 centimeter and axillary lymph nodes. The biopsy revealed an invasive carcinoma NOS high grade triple negative. Next, please. So the diagnosis is stage 3A, triple negative, right breast cancer, T3, N1, M0. She was recruited in a clinical trial, so she received neoadjuvant chemotherapy with carboplatin plus docetaxel times 2. She developed toxicity, elevate transaminase, grade 3 after the second cycle. And she recovered after 4 months after the second dose of chemotherapy. The response, clinical response, she had a complete in the breast and axilla. Next, please. She had a mammogram and an ultrasound and revealed an architectural distortion in the left breast in the upper inner quadrant and no tumor evidence. The surgery not found an invasive carcinoma with complete pathological response. Then she received radiation therapy to the supra and infraclavicular area and a boost in the breast. No adjuvant therapy offered, and currently he is not evidence of disease.
Hugo, just give me a second to remind everybody to please mute your microphones while he's presenting the case so everybody can hear. Please mute your microphones. Thank you. Okay, continue, Hugo.
Next, please. Now the questions. The first question is, with complete clinical response early during neoadjuvant chemotherapy, can surgery be planned earlier? And which is the best surgical approach?
Okay, so let's do it one question at a time. Seema Khan, would you like to comment on the question? Really is about achieving a complete remission, although you wouldn't know that pathologically during the neoadjuvant therapy, but a complete clinical remission during neoadjuvant therapy. Would you ever go ahead before the completion of a planned course of neoadjuvant chemotherapy? That's the question. Can you go earlier with surgery? Seema, we can't hear you, sorry.
Sorry, I was muted. So there should be a good reason to stop early if the patient is not tolerating it, or there are other logistical barriers or problems like that in a woman who is tolerating treatment and the treatment is logistically feasible, it would be best to continue to the full course. So the planned number of cycles should be delivered because, as you said, imaging is not reliable, neither is physical exam, and so a complete clinical response doesn't predict a complete pathologic response necessarily, and we would like to see the maximal response. So unless there is a good reason to stop, I would continue with the course.
So I'm just going to have Michelle Gare. Michelle, would you like to offer a surgical opinion on this?
I agree. I think the systemic therapy is a very important part of her care, and I think sometimes what we've seen actually is if we do have therapy already set up, part of it followed by surgery, followed by additional chemotherapy, that with the tremendous responses that we see with systemic therapy and no evidence of disease after surgery, patients have been reluctant to finish their systemic therapy, so I think it's best to get it done initially and not cut short.
And maybe Seema and Michelle, you could comment on the prognosis in a complete pathological remission. What is the prognostic value of a complete pathological remission at surgery? Does she need further adjuvant therapy? Is it sufficient? Oh.
So complete pathologic response, as we know, does indicate very significant sensitivity of the tumor to the regimen that's used, that would imply that micrometastatic disease has also responded well. So it does result in a very dramatic improvement in disease-free and I believe also vital medical.
But you would always recommend completing an adjuvant course of chemo despite pathological remission or not? That's the question.
So our pattern is to plan out the systemic therapy based on the tumor characteristics and then to deliver it preoperatively if possible. If it's not delivered preoperatively, then one could consider completing it postoperatively, even if there is a complete pathologic response. I think that would be our approach.
So, sorry, just let me rephrase. Let me rephrase, please, Seema. If you have a full course of chemotherapy delivered neoadjuvantly and you've got a complete pathological remission, there is no longer a need for further systemic chemotherapy. Is that what you're saying?
Yes. I mean, unless it's endocrine responsive or hormone receptor positive, then of course one would continue with endocrine therapy. But as far as cytotoxic therapy is concerned, if the planned course is delivered preoperatively, complete pathologic response, there is really no need to continue postoperatively. Right. And then I'd like to hear medical oncology opinions on the situation where there isn't a complete pathologic response. So what is the role of non-standard therapy after partial response?
So maybe it's time to have Susan Sajay. Would you like to respond to that comment?
Yeah, so I think we honestly don't know the role of additional adjuvant therapy in patients who received a standard course of preoperative therapy or neoadjuvant chemotherapy. So I think our practice right now is for patients who have received standard treatment, we just follow them clinically, understanding they're at very high risk for relapse. But I think this is an area for active research. I think with regard to this case, this patient did not receive standard adjuvant treatment preoperatively because of complications. So I think after surgical recovery, this would be a patient we would normally recommend additional chemotherapy, clearly off protocol, but that's what we would do.
So let me paraphrase, please. The approach I'm hearing is to give a standard course of adjuvant therapy as planned by biology in a preoperative setting, and if you achieve a complete pathological remission, no further treatment is standard. And if there is, it's been an atypical regimen or it hasn't been able to be delivered properly, then you complete it post-operatively. I think that's what I'm hearing. Is there anybody else from medical that would like to comment? Ben, would you like to say something?
Yeah, I think that from what I understood of the slide, that this was actually a trial correct, of neoadjuvant therapy, and so those wouldn't be considered necessarily standard of care therapies. And so I'm in agreement that I think in this particular instance, if she had residual disease, I probably would talk about and recommend a more standard adjuvant therapy after the surgery. On the other hand, if she achieves a pathologic complete response, I think there is some debate, even with an experimental neoadjuvant approach, whether or not the patient really will benefit from additional chemotherapy. As we know, in triple negatives and high-risk HER2 positive types of patients, pathologic complete response is associated with better overall prognosis, but it's not a perfect one-to-one. And so I think there's still room for debate whether, in this particular case, even if she achieves a pathologic complete response at surgery, whether or not there's a role for additional standard adjuvants. I don't know if, Rasheen, you would add to that or not.
Yeah, I just wanted to add that for a patient, for example, who has received all their therapy pre-surgery and who has residual disease, we do have a cooperative group study now open for those patients who have a basal triple negative phenotype. So Ingrid Meyer is the PI for that study. So patients who have, for example, ACT or some TC for 4 to 6 cycles who have residual disease, we wouldn't standardly give those patients additional chemotherapy off trial, but there's now a study randomizing patients to platinum versus no platinum.
That's great, Rasheen. And we will distribute the details of that clinical trial to the entire viewership after this tumor board, so don't worry about taking notes or anything. We'll distribute after the tumor board today. So that's great. We have one more surgical expert who's joined our conference, Michelle Specht, and Michelle, the debate has been, a patient receives standard full course of neoadjuvant chemotherapy, obtains a complete pathological remission, and the question from Peru was, would you give further, would you ever interrupt the chemotherapy if the clinical response seemed complete during the neoadjuvant and stop and go on to definitive surgery then? Or would you wait for the full course and then do the definitive surgery? That was the first question, actually. So is there a role for stopping neoadjuvant chemotherapy early?
I think fundamentally if you're using a regimen that's a tried and true regimen in which we have good long-term data, you want to complete it because we know that those regimens, when everyone receives everything they're supposed to receive, have a likelihood of higher disease-free survival. There are times that in a research setting we've been splitting chemotherapy and doing a sandwich approach to give us some ability to test novel agents. But I think from a standard approach, our clinical exam doesn't always match what we see pathologically, and best to get all the drugs in.
Right, so I think everybody on the panel is saying the same thing. So if I may, can I just take over, Hugo, and pose the last questions? What they've asked is, would the role of knowing a BRCA1 mutational positive patient help towards planning the type of neoadjuvant chemotherapy? And maybe, Ben, you're one of the most qualified people to answer this. You and Rasheen can comment. If we knew this patient was BRCA1, 2, would you alter the neoadjuvant chemotherapy with a triple negative BRCA1, 2 disease versus not BRCA1, 2?
We discussed, I think, a similar case, and our policy right now has been that this is not standard of care, that we, off study, we would still use standard of care regimens in the neoadjuvant setting. However, the one instance when we might consider adding a platinum agent would be in a known deleterious BRCA mutation carrier. And again, I think we had similar conversations a few months ago. But that would probably be right now in 2015 the only exception, and even then, that's not black and white. That's still a very gray area.
And I think that's the same policy at MGH. The only time we use platinum in triple-negative breast cancer routinely is in known BRCA1, 2 carriers, either neoadjuvantly or adjuvantly, I think. Well, neoadjuvantly.
Right?
Say it.
We have the INFORMED trial that's open. Susan, can you comment more on the trial? I forget the details.
Yes, the trial is a randomization between neoadjuvant AC dose-dense fashion versus 4 cycles of cisplatin, and then their surgery, and then depending on their response and the patient's and physician's choice, they can have whatever additional chemotherapy post-operatively. And that's
called the INFORM trial, right? The INFORM trial.
And it's just for BRCA1, 2 carriers.
Okay, thank you. So maybe, Ben, could you take the microphone again and talk about any new emerging exciting targeted therapies in clinical trial or in clinical practice for triple-negative breast cancer?
You know, I wish I could tell you that there's tons, but there really aren't. We are participating in a trial looking at, this is a metastatic trial, looking at a novel protein where we have an antibody. I can't remember the name,
GCDFP.
Yeah, GCDFP. And ironically, the name would suggest that it's overexpressed in benign tissues, but in fact, it seems to be overexpressed in a lot of malignancy, in particular triple-negative breast cancer. But again, people have been looking at whether PARP inhibitors, we can kind of figure out whether there's a predictive signature based upon homologous recombination defects and repair. I don't know if that's really ready for prime time yet, and I think that time will tell. I still think, based on the way that PARP inhibitors and platinum drugs were discovered simultaneously in 2005 in back-to-back Nature papers using isogenic cell lines between BRCA normals and BRCA null, that really is the best predictive signature, and I think that that's kind of been borne out with the latest clinical trials. But for triple negatives right now, unfortunately, you know, we're looking at various things right now, FGFR family member amplification, etc. But there's not a huge, you know, this is a great target for all triple-negative breast cancer.
And Ben, can you remind everybody where exactly we stand with the PARP inhibitors today?
Well, so we know that they are approved for subtypes of ovarian cancer, but they are not approved right now for any setting for breast cancer. I think there are a number of clinical trials that have completed, and we're awaiting the results of those. AbbVie has their veliparib, you know, AZ has their drug veliparib, and so there are many PARP inhibitors that are slowly percolating down the pipeline, and I suspect that at some point they will get approved. Rasheen is actually part of our phase 1 group, or co-leads it, so you might have some other insights into this.
I think just the other big area to mention is obviously the immunotherapy agents, the immune checkpoint agents, right, which people are focusing on triple-negative breast cancer and developing studies even now in the neoadjuvant setting with very early data in metastatic disease. So I think this is definitely an area to watch. But on study.
And we are just reporting a negative neoadjuvant trial with the WT1 and an antibody to the WT1, Wilms tumor antigen 1. And it was a negative trial in all subsets of breast cancer. We actually treated ER positive, triple negative, and HER2 positive, and they were all negative. And we're writing up that paper right now. So that didn't go anywhere, but that's another area. Antibodies are another, and immunotherapy is another area of research right now.
And I would add to that, I don't believe that, you know, immunotherapy is going to be the magic bullet for all triple-negative breast cancers. What we're learning here at Hopkins, and there's several papers to support this, that it seems to be that the cancers that have the highest mutational load, i.e. creating the most neoantigens, are probably going to be the ones that are most responsive. And when one looks across the successes, it really are the microsatellite unstable colorectal cancers, melanoma, and then certain subsets of lung cancers. And there's a clear separation between the amount of mutations in those subtypes that have generally responded to immunotherapies and everyone else. We're hoping that this can be replicated in some types of breast cancer, but again, I think we need more research.
Good. If you don't mind, I'm going to try and move on because it's just in the interest of time. Pedro Litka from Porto Alegre in Brazil. Would you like to present the second case, Pedro?
Sure. So, our case is a 53-year-old postmenopausal woman. Had a maternal aunt with breast cancer at age 60, no other important medical history. Second quarter of this year, she underwent screening mammography, which found 2 new nodules on her right breast, one measuring 2 centimeters and one measuring 1 centimeter. Physical exam, she had actually, you couldn't palpate separately these nodules, so it was a 6 centimeter mass, retroareolar right breast, no palpable lymph nodes. Next, please. She underwent a core biopsy of this tumor, which was an invasive ductal carcinoma grade 2, and the immunohistochemistry of this core biopsy done outside of our institution showed a ER positive, PR positive, HER2 2+ tumor, and then she was the tumor underwent CISH testing, and HER2 was not amplified. Patient received AC 3 weekly times 4, followed by docetaxel 100 milligrams meter square every 3 weeks times 4. She had moderate to severe toxicity with febrile neutropenia, mucositis, needing dose reduction. After she had finished her neoadjuvant chemotherapy, the tumor had a partial response. It was 3 centimeters on palpation. At this time, we decided to review the immunohistochemistry at our institution of the core, of the original core biopsy of the diagnosis. And in this second review, we had an ER positive, PR positive, HER2 3+ tumor on the IHC. She is planning breast conservative surgery in the next few weeks. So we have a tumor, and the same specimen of the tumor that has a testing of positive IHC and a non-amplified CISH. And the question is, should this patient receive Herceptin?
Anybody? Maybe Ben would like to comment again.
Can I just ask the CISH? I'm presuming that's like some sort of different substrate rather than fluorescence for fish or chromogenic.
It's silver with silver staining.
Okay, so I'm not as familiar with that, but do you also have whether or not there was the absolute number of HER2 gene copies per cell? Meaning, was it in the what we call equivocal range of 4 to 6 or higher, which would make it positive, and then also whether or not they reported out which chromosome 17 centromeric probe they used and what the number of that was per cell, because that could lead to a false negative ratio.
Okay, I don't have that information with me. I don't have the full test result. We use a lot of silver staining here in Brazil, and this test is actually, Roche has actually put this test in several hospitals and does these testings because we don't have access to fluorescence microscope. But it's the sort of, as I've been explained by the pathologist here, it's the same technique. Instead of using fluorescence, they use silver staining. But I don't really know the details of the.
No, and in KISH, chromogenic in situ hybridization is also an acceptable technique. So I think that part of it, as long as the controls are good, should be fine. But one of the things that can lead to a false negative HER2 ratio is having co-amplification of the chromosome 17 centromeric probe. And when that happens, usually what labs will report out is what was the absolute copy number of the gene and the centromeric probe per cell. If it would suggest that there is co-amplification, one can do a number of different things, sending the test out again with a lab that uses a different centromeric 17 probe. Mayo does that. There's another company that just came online called Neogenomics, or at least the first time I ever heard of it, and they actually use 4 or 5 alternative chromosome 17 markers, including P53, RAR alpha, etc. And we've had results where, in fact, clearly there was co-amplification with the standard marker, and the rest of the chromosome 17 looked normal, and therefore it was actually considered HER2 positive, and that might explain discrepant results.
Okay.
So I think in the short, for something like this, if you have any doubt, I would go back to the CISH, kind of figure out whether there's any equivocal testing result or not. If it still looks somewhat equivocal, I might try to repeat the testing independently in another lab to see whether or not this is really HER2 positive and use that as a tiebreaker. And I'm pretty sure that would follow ASCO and CAP guidelines.
You'd repeat the test on the original core, or my next question would be, is there any role for testing this? If she's undergoing surgery, we'll have the whole tumor or the residual tumor. Should this be tested, and then should we use this as the final result or whatever?
Yeah, I mean, I think you could do that. It's always questionable after neoadjuvant therapy what effect did the chemo have potentially on cells. Particularly if you got anthracycline, because there are some stories that TOP2A, topoisomerase 2A, which is next to HER2, can also be co-amplified, and you can have a pretty rigorous result getting anthracycline. If you looked at the BCIRG 006 trials, the 2 arms where they had AC and T, but one with Herceptin and one without, retrospectively, so take this with a block of salt, retrospectively, if one looked at TOP2A amplification, the results of the benefits seem to be equivocal. So even in the absence of Herceptin. So I'm not sure I would necessarily trust the post-treatment surgical specimen as much. You might want to think about if you have enough to go back to the core.
Okay, if you don't mind, guys, I'd like to cut this very interesting conversation a bit short because I'd like to give Dr. Vanessa Dabral. We started late and I do apologize, but I want to give Vanessa from Salvador a chance to present her case in our remaining minutes. So Vanessa, if you're there, can you get ready to present your case, please?
Yes. Okay, so we have a woman with 36 years old. She's BRCA negative, and 5 years ago she had an invasive ductal carcinoma of the left breast. It was a bifocal disease with one lymph node positive. She had a left mastectomy and a maxillary lymph node dissection with reconstruction. And the tumor was hormonal receptor positive, HER2 negative, and she had TEC, adjuvant TEC, and tamoxifen. Next, please. After 4 years of adjuvant tamoxifen, now she presents 2 nodules in the left breast, the same breast that was that had surgery in the past. And the core biopsy was an invasive ductal carcinoma with the same characteristics of the past one. So next, please. So it's a 36 years old woman who presents hormone receptor positive invasive ductal carcinoma in a reconstructed breast, post-mastectomy and axillary lymph node dissection, while on adjuvant tamoxifen. The previous tumor was a T1N1N0, hormone receptor positive, HER2 negative, and the new tumor is a clinically T1 with the same characteristics. She did not receive the surgery yet. So the questions for this case is, what is surgery that you would propose for this patient, including reconstruction? If you consider prophylactic mastectomy in the contralateral breast, even if she is BRCA negative, do you consider adjuvant radiation therapy? She did not receive adjuvant radiation in the past. And which is the best hormonal adjuvant therapy that you would consider? And if using gosuraline, do you consider to use the an aromatase inhibitor based with only on estradiol levels, or based on the rise of the FSH? Because our young patients, we had a delay, a considerable delay to the rise of FSH.
Right, so thank you. Those are all interesting questions. Do you want to kick off with surgery, perhaps? Anybody?
I mean, I think we need to understand where these nodules are. Are they close together? Is this something that you could accomplish with a chest wall excision in order to achieve negative margins?
Sorry, I didn't understand
Would you
the question.
excise it
Sorry.
without taking the implant down and be able to get a clear margin on this?
I think yes. The nodules now are not fixed in the chest wall or in the prosthesis. It's near but not fixed. But we don't know if we could have clear margins until on the surgical procedure, I think.
Where are the nodules?
In the inferior medial quadrant of the breast.
Inframedial.
Both of them.
Is that where the original, no, the original tumor, were the two nodules there also?
No, it was in another quadrant, the best ones.
So perhaps this is this subcutaneous metastasis, or do you think residual breast tissue?
We don't know at certain. She did not have a lot of residual tissue, breast tissue after the mastectomy and reconstruction. And in the same time, the nodules don't seem to be at the skin, you know. We don't have skin alterations in the when we see clinically. So it seems to be subcutaneous nodules, but we don't know at certainty that it's not breast tissue, residual breast tissue that remains there.
I agree with Michelle.
Sorry.
I agree with Michelle.
Can I make a comment?
Just 1 second, Seema, please.
I'm sorry.
What? No, go ahead, Michelle.
I was just going to say I agree with Michelle. I think it sounds like it might be resectable, but I would probably stage her first to make sure there's no disease outside the breast. And then if the medical oncologist felt like they wanted something to follow, it wouldn't be necessary to immediately resect these if that would help define the best next treatment, which is probably going to be endocrine, actually. But sorry, Seema.
Seema, would you like to comment?
Yes, so I think it's really important here to distinguish between new primaries and chest wall recurrence. And for a young person like this, what was the disease-free interval? I missed the
4 years. 4 years.
Sorry?
4 years, and it recurred on tamoxifen.
4 years, yeah. So at 4 years in someone like this, I would really think of this as a chest wall recurrence rather than a new primary. I think the parameters that have been defined to call a lesion like this a new primary include things like the presence of breast parenchyma and the presence, you know, of ductal structures, and even DCIS. The presence of DCIS may indicate that it's a new primary. But really, this has all of the hallmarks of a chest wall recurrence than a new primary. So in that case, then the question of a contralateral mastectomy is really not an issue. The question of the local therapy for this, I would agree with wide excision if that's possible. And in our institution, I think normally we would take down the implant and then refer to radiation oncology. So Alphonse probably will have some comments, but
and before, sorry, Seema,
like
Seema, let me please ask the two Michelles, what about contralateral mastectomy? Seema says no at this point.
It would not be high on my list of a priority. I think we need to complete the treatment of this.
So we're getting consensus among 3 surgical opinions that contralateral mastectomy is not the next surgical step to take. First deal with what we've got present now, and then think about it afterwards. And now radiation, Alphonse.
Yeah, so there are 2 comments here. One, if we go retrospectively 4 years ago, if I have a 36-year-old patient with 1 positive lymph node and mastectomy, I would actually have given her post-mastectomy radiation. And I know this 1 to 3 positive lymph nodes was a gray zone area many years ago, but it's getting less and less in the gray zone because the meta-analysis showed that there is an advantage in giving post-mastectomy radiation even if the patient has 1 positive lymph node. And they actually did an analysis for women who had 1 positive lymph node. And they had few thousand patients in the meta-analysis. So that's 1. 2, now we have a local failure which can be excised by surgery. I would certainly give radiation at this point, and I would cover the chest wall as well as the supraclavicular area. I would not go to the axilla because it has been resected quite strongly with 36 lymph nodes, I think, so her risk of lymphedema will be quite high. But I will give just 50 gray, maybe a boost around the scar from the 2 recurrences, and I will give also 50 gray to the supraclavicular area. Otherwise, more local failure can come.
And Carol Marquez, do you want to add to that, please?
I completely agree. I think this patient, she's actually, if she can get a wide excision and her staging is negative, she's in a relatively good prognostic group of chest wall recurrences because she still has radiation to be given, she still has endocrine manipulation that can be done, so I would be aggressive with the radiation. I would even consider including the internal mammary nodes given the location of her recurrence because it's in the inner quadrant. And you're not going to see an axillary node involvement to help guide whether or not you think the internal mammary nodes are involved because they've been resected. So I would probably include the internal mammary nodes just to be admittedly more aggressive, but more certain that I'm treating any micrometastatic disease.
So would you mind, Carol, would you mind just summarizing, because Alphonse is nodding his head and agreeing with you, would you mind just summarizing the total radiation fields that you would recommend for this patient now?
Yeah, so I would radiate the chest wall, supraclavicular fossa, and internal mammary nodes, and I agree that the axilla doesn't need additional treatment. And I think 50 gray is the appropriate dose. And I wouldn't do a boost. I might do a boost to the excision. It would kind of depend on how the surgery went, what the excision was, what the margins looked like. I might consider a boost to that where the recurrence was.
Thank you, Carol. So we now have the floor open for discussion about the role of subsequent adjuvant endocrine therapy after relapsing on tamoxifen. And so the question really is a very interesting one that I haven't seen asked before. With the decision to use goserelin plus an AI, or perhaps just an AI alone in this patient, is it based on a serum FSH level suggesting menopause or not? Or is it based on serum estradiol levels? And I think that these two markers are frequently used and misused by various people, and I'm very interested to hear other people's opinions. So Rasheen, perhaps you, and then Susan and Ben, if you'd like to comment on the adjudication in your clinic whether a patient is or is not menopausal after the use of tamoxifen.
So I think it's a very difficult question sometimes. I think one question is whether hormone levels are taken while the patient is still receiving tamoxifen, because oftentimes they may not be accurate in that setting. But our practice here is usually to be overcautious, and usually we like to test all three of the hormone levels, the LH, FSH, and estradiol, and if we have any concern that the patient is not postmenopausal, we err on the side of giving the goserelin.
And can I just add, Rasheen, to the fact that your first comment about taking the serum levels on tamoxifen, the problem, as we all know with tamoxifen, is when you stop it, you're not really off it for a long time. It's got a tremendous half-life in the plasma and a tremendous longer half-life in the tissue. So I personally think that the serum hormone levels are not a very good prediction of menopausal status, no matter what they show on a given day, because it's like predicting the weather tomorrow based on the weather today. As you know, patients often have a recurrence of menses up to 18 months after stopping tamoxifen or other things. So I think this whole area of adjudicating on menopausal status on biochemical grounds is very tenuous indeed, actually. So I'm interested to hear, Susan Sager, your practice. What do you do with these patients?
So I have a similar comment to the group from Hopkins. So for us here, if they have amenorrhea for more than 2 years, LH, FSH, and estradiol all in the postmenopausal range, that would be a patient who you would consider an AI alone. With the
and you don't, Susan, you don't use age as one of the criteria to decide.
Well, my second piece of it is if you're needing to switch a patient's hormonal levels, the younger the patient, the more likely they're going to have reactivation of menstrual function, ovarian function with an AI. So I think the data supports under the age of 48, probably 30–35% of patients will become premenopausal again. So if you do need to switch, even with all the normal parameters, you have to really watch those patients. So you know, you can watch with all 3 hormone levels at 6 months, and if anything looks like they're becoming premenopausal, then you have to add in ovarian suppression. You know, this patient's quite young, that I would bet all of her markers are not going to be postmenopausal.
So it's quite a big decision, and I think one that lots of people struggle with. There's no perfect answer to this particular question, in my view. But I concur with what Susan just said. A patient below 40, no matter what chemotherapy they've had, no matter what endocrine therapy, no matter how long they've been amenorrheic for, you cannot depend completely on not resuming menses. I think it's more common than not. And in fact, I have at least a dozen cases in my past life where patients on tamoxifen and amenorrheic for years and years have presented with pregnancy without realizing they are still fertile and still ovulating, and they don't have any menses. So I have these tamoxifen babies that were conceived when the patient was completely amenorrheic for over 1 year on tamoxifen. So just a caution about tamoxifen and its adjudication of ovarian function. Any other comments about this particular point? I think it's a hard one. So I think that in the interest of time, we're just on the hour, and we started late, but I want to say that Mayra Tavares from AMO did prepare a case, and we're going to hold that over, Mayra, if you don't mind, for our next tumor board. I think we've had a very good discussion on 3 interesting cases. I'd like to thank the presenters very much. And I'd like to also do a shout out for Ben Park. So on March the 7th next year, we've invited Ben Park and Aditya Bhatia from here at MGH to run a kind of mini didactic symposium, perhaps with a case to exemplify a certain phase 1. Maybe you better describe it yourself, Ben. Would you mind describing what we've invited you to do?
I think, you know, at least in the United States, there's an ever-increasing use of mutational profiling for breast and other cancers. And one of the conundrums of this, even though it's exciting technology, is that we don't really have definitive evidence that this actually makes a difference or has clinical utility. And from that arose a need to have a molecular tumor board here at Hopkins, something that I've discussed with Aditya, and I think he's trying to also emulate at MGH. But to really actually try to discuss cases, and again, these are almost always from metastatic patients, and try to figure out what actually, when you see a report, makes sense in terms of what is called an actionable mutation by the institute or the company versus we as breast oncologists, what do we really view as an actionable mutation? Is this really something that provides sound rationale for targeted therapy on a clinical trial or otherwise?
So Ben, we're very grateful to your offer to do this, and we're very excited about this. Please put a note in all your diaries for March the 7th, 2016. And I think we're going to have a very exciting meeting with 2 world experts on mutational analyses and what targeted therapies for stage 4 breast cancer. So mark that, flag that in your... We will distribute the clinical trials that were alluded to today, the details of those. And just to remind you that the slides are available from today's meeting online. We can point you to them, and so is the video clip from today's meeting. The entire tumor board was recorded live, so it's there in the archive for anybody, your residents or fellows or anyone else to view. Thank you very much for attending, everybody, and we look forward very much to next time. And we're going to the Dominican Republic present a case next time. Thank you very much.
Thanks.
Thank you, everybody. Well, then.